we are now changing tracks from structural, highly competitive structural arena to now the coronary again, and that too in the imaging arena. And the topic allotted to me was optical coherence tomography in left main, which is slightly a controversial issue. What are the options and the challenges? I have designed my talk under certain questions which I would answer throughout my talk. Why should I do imaging in left main PCI? And if I do imaging, why at all OCT? And when should I do the OCT? Where is the data for the OCT? And then if I am doing the OCT, then what are the tips and tricks to improve the OCT images in the left main? So coming to the left main, it's not that uncommon. It's seen in 4 to 6% of the patients undergoing angiography, supplying 70% of the LV in the right dominant system and almost all in the left dominant system. 9 to 10% of the cases have only isolated left main disease, and bifurcation disease is the most common presentation. And even in acute coronary syndrome, 4 to 7% of the patients have significant left main disease, which we should be cognizant of. So earlier, the traditional method of revascularization of left mains was surgery. You can see that the PCI was class 3 indication. But as the intervention advanced, the techniques advanced, the balloons, stents, delivery system advanced, the indication is gradually stepping up from class 3 to class 2A and the low risk syntax even class 1. But how this has become possible? It's basically possible because of the advanced techniques, and the role of imaging is also paramount in this. So why should we be considering imaging in the left main at all? Because we are directly competing with the surgeons on the other hand. They are breathing down our neck to have a better result in the left main, which was earlier their domain. So we have to be very precise in placing our stent, choosing the size of the stent, choosing the different technique of stent, whether it's a single stent or a double stent. So if we rely only on a coronary angiogram, which is a shadowgram, luminogram, it has a lot of inter-observer variability because of the different aspects of shortening of artifact, spasm, eccentricity, or diffuse disease. Or you can sometimes, even despite your best efforts, you can't find a good angiographic view for the ostial left main. Left main comes in variety of shapes and sizes. No one-size-fits-all approach would be suitable for angioplasty if we decide only our intention based only on angiogram. So that's the reason we should have some other method for quantifying and classifying the left main disease. But why should I do imaging? There are numbers of trials for the non-left main arena, especially for intravascular ultrasound, which have proven its supremacy of imaging-based interventions over non-imaging based. So the first time when the left main imaging was studied was an Excel sub-study in which what they have used, and when the imaging was done, especially in the intravascular ultrasound, they used larger balloon, post-dilated more, and used higher pressures and achieved higher MSA. What was the importance of achieving a higher MSA? You can see that in the higher MSA tertile, that all the high risk, the death, MI, stroke, all the target lesion failure, they were much, much lower than when the low MSA was achieved. So based on these, encouraged by these results, people have come out with the exact criteria for left main intervention, when to do, when not to do, but these were IVUS criteria, like less than 4.5 MLA, you should do the intervention, more than 6 millimeters, you should defer, and in between, you should take help of FFR. So, but can we apply these IVUS criteria in the OCT arena, because the resolution is different? So, to answer this question, a study was done, and it was found that the MLA measured by optical coherence tomography is significantly smaller than the intravascular ultrasound. The FDOCT MLA being 10 to 15% lower than the IVUS MLA. But despite this, so we cannot use the same cutoffs as of IVUS in the OCT. But despite this, still people are using OCT in left main. Why? Because of the excellent resolution given by the OCT of 10 microns axial resolution as compared to 100 microns of intravascular ultrasound. So, but does this excellent resolution translates into some clinical relevance? Let's find out. You can see the comparable images in the IVUS on the left, on the OCT on the right, how precisely you can see the malapposition, you can see the dissection, which is difficult to imagine in the intravascular ultrasound. You can see the plaque characterization, the new intimal hyperplasia, lipids, and calcific lesion, which has a bearing on your selection of your device as well as the technique. Especially in the calcific lesions, because the IVUS, the sound does not penetrate calcium, so we don't get to know the depth of the calcium. The light penetrates, so OCT can define how many microns the calcium is thick, whether we should be using any debulking device or not, and if we are using, which debulking device we should use. So, and one area where OCT is paramount is in the in-stent restenosis, because here this is very important to ascertain the mechanism of the ISR, whether it was an underexpanded stent, whether it was a malapose stent, or whether it's a new intimal hyperplasia or new atherosclerosis. None of it can be very easily diagnosed by intravascular ultrasound also. So when should we do an OCT while planning an left main? First, to understand the disease severity and morphology, but do we have a data? What are the guidelines say? In the disease severity and morphology assessment, the guidelines does not include OCT. The place is taken only by intravascular ultrasound, class 2A indication. And for optimizing treatment of unprotected left main, also we don't find OCT as a class 1 or class 2 indication yet. So where is the data for OCT in left main? The ROC1 study, which was conducted in 3 European centers between 2014 and 17, with a control arm of angiography and another arm of OCT. And the results were studied by a blinded core lab where they analyzed all the angiographic studies and the OCT studies. The primary endpoint being the in-segment late loss of left main and side branch at 6 months to 12 months. And what they found was, in the OCT group, they found about 8% of the cases the stents were underexpanded, and about 12% of the cases it was acute malapposition, and which translated into a better outcome. The late loss in the OCT group was lower than what was there in the control group, though it was not statistically significant. So they concluded, this was a retrospective study, they concluded that yes, OCT is feasible in left main, and it allows easy detection of the acute stent under expansion and malapposition, and it shows a trend towards improved outcome at midterm compared to angiography guidance only. But are there any comparative study of intravascular ultrasound versus OCT in left main? As an offshoot or the follow-up of ROC1, the ROC2 study was planned again in the European centers, and where they compared directly with the IVUS and OCT versus angiography in patients undergoing distal left main stenting. The primary study endpoint was target lesion failure, including cardiac death, TVR, and TLR. And this study was, the hypothesis was to establish superiority of imaging over angiographic guidance alone, and the non-inferiority of OCT versus IVUS in the left main scenario. And what how they did was 730 patients were included, half of them were in imaging group and half were there in the angiographic. And what they found was the 1-year target lesion failure was substantially better in the angiographic arm than in the intravascular. There was no difference between OCT and IVUS. So when they compared with the imaging and angiography, there was a difference which was significantly better, 20% target lesion failure in angio group and 13% in the intravascular. But when both the imaging modules are compared, OCT versus IVUS, there was no difference. So imaging was superior and IVUS was non-inferior to OCT. So the conclusion of this study was intravascular imaging is superior to angiography for distal left main stenting, with no difference between OCT and IVUS. Can OCT superior resolution of a more than IVUS in guiding left main PCI. Insights from the Lemon study. This was a French study in which OCT was done at about 3 or 4 times during the study in all the levels of identifying the plaque composition, morphology, wire position. And what they found was that, I'll just skip it, the primary endpoint was feasibility. The procedural success was 86%, which was TIMI-3 flow in all vessels, and adequate stent extension, which was 86%. And so OCT found something which was better than intravascular ultrasound, more accurate identification of early PCI pitfalls like malapposition. You can see that malapposition found in 51% of the patients in the proximal segment and 30% the distal segment. And the accurate wire position also was very well delineated in left main intervention, which has a bearing on our outcome. So this concluded, this was the first prospective study. The ROC1, ROC2 were retrospective study. This was the first prospective study for OCT guidance, and it shows the good feasibility and safety of the technique. So, but we should be cognizant of certain OCT artifacts. The most common artifact is the blood swill, because it's in the left main. So we have to be, I'll tell you what are the tips to reduce that blood swill. You have to, your acquisition technique should be precise. You have to be coaxial. The catheter should be coaxial. Look for a better guiding catheter alignment, and always take a test injection before start OCT with one wire first, and then put a second wire for the second branch. Your injection rate should be higher. Sometimes you can use your guideliners also for ostial demonstration. So, and you should also know where your stent begins, because for accurate placement also. So the take home points, ladies and gentlemen, is imaging helps in all the stages of left main PCI, from planning to execution to detection of complications. Though the choice between IVUS and OCT is debatable, but the IVUS scores over identifying ostial left main issues, while there is no difference between OCT and IVUS for distal left main bifurcation. In in-stent restenosis and calcified lesions, OCT has an edge over intravascular ultrasound. So in my opinion, the intravascular imaging should be made a class 1 indication, at least for left main PCI. Thank you very much.